Hello, and welcome to MOASC's annual professional education series for oncology administrators. My name is Nicole East. I'm the executive director of MOASC. Today, we have a fantastic lineup of speakers to discuss how you can optimize your practice's profitability and specialty carve-out programs and what they mean for your patients. If at any time you have any questions or comments, please feel free to type them into the chat box or unmute your line. I'm pleased to introduce our first speaker, Deborah Ferris. She is president of Practice Liability Consultants, an experienced practice management consulting company with 35 years experience. Since 1985, they have worked with over 2,300 practices of all sizes and specialties. So without further delay, I'll turn it over to Deborah.
Thank you, Nicole. Actually, it's 38. I guess I didn't update the bio. So yeah, it's longer than I thought, but thank you for having me. I really appreciate it. I may have, if any of you belong to MGMA, I've spoken several times to California MGMA and to the Southern California MGMA as well. And I'm very involved with Northern California MGMA, but I'm delighted to be working for a specialty organization as well. So let's get started. And that's me, in case you forget what I look like. And I have no disclosures or conflicts of interest to report. I might mention a few things, but no conflicts or anything. I like to try to give you some resources if I have them. And, I like Peter Drucker. I went to MBA school, so I love Peter Drucker. And, we all have these responsibilities to make a profit, to satisfy our employees and our customers who are our patients. And we need to be socially responsible. Those are all things that really matter to any business, including healthcare. So benchmarking, so important. And that's comparing best practices, key financial data with your specialty peers to identify areas, strengths, and weaknesses to improve your financial picture. Now, your specialty is very specific, and you can't compare your specialty to family practice, for example. So you need to have data that's very specific to your specialty. And I have pulled data for you. I'm very lucky is that I'm a member of the National Society of Certified Healthcare Business Consultants. And we're an organization of generally small, very small consulting organizations. And we have negotiated with MGMA, AMGA, and Sullivan Cotter to get some of their data at a reduced cost, because there's that purchase it as a group. So I do have access to this data, and it does cost me quite a bit a year, but not like it would be if I was a solo person on my own. So I'm going to give you as much as I can, and it is proprietary, so I'm not supposed to be sharing it with the world. But anyway, I like this quote from Harvard Business School: "You can't manage what you don't measure." And I think that's so true, is that we all have to be looking at all of our data, and we have to get the data in order to negotiate, particularly if you are being managed by a management services organization, a university, a private equity, a hospital, a foundation, whatever it may be. You do need to have data to negotiate and so forth. So we're going to talk about that at the end with work RVUs and dollars per work RVU and things like that. And I like this quote. You might remember this guy: if you don't know where you're going, you might wind up someplace else. So you really do have to look at all this for the future and really look at it. So it starts with good profit loss reports. I mean, we really need that. And obviously QuickBooks is the gold standard. QuickBooks Online, I think, is really where we need to be. And I like to see that the CPAs have access to be able to get into the QuickBooks Online so they can make some minor corrections to the chart of accounts and general ledger if they need to. And they shouldn't get access to the bank accounts or anything like that. I have an outside bookkeeping service, and they actually can look at I've given them permission to do the QuickBooks Online, or look into it, and then also to reconcile my bank statement and also my business credit cards. So I like that. They handle all that. That's the stuff that I do not like doing. So train managers, absolutely explain it to your CPA that your profit loss report is a management tool. It's not just for tax. You need to use it as a management tool, and you need to scrutinize it every month and looking for trends to nip negative ones in the butt early. I can look at profit loss reports and catch things all the time, including that I caught embezzlement for one of my doctors I knew something was wrong because he said, I'm working just as hard as I ever was. I don't understand it. I'm not making more money. And I looked at 3 years of profit loss, and I looked at the office supplies expenses going up, and they were way higher for that specialty than they ever should be, because I know all the specialties. And I said, something's wrong here. And sure enough, the office manager was embezzling. She was actually paying for her kids' college education by transferring money online to herself. But anyway, the doctor never looked at anything, gave her total power to do everything. So as the lawyer said, he gave her the keys to the kingdom. So anyway, that was a terrible thing. She took over $250,000 over a 3-year period. So in any case, data reports, these are the big ones that I think you need to have access to one way or another: Sullivan Cotter, American Medical Group Association, and MGMA. And then your specialty society. Hopefully, maybe through this organization, my hope is that you're collecting data and you're being able to share that data. So Sullivan Cotter, let me explain to you what the survey participants, what their makeup is going to be. Sullivan Cotter is primarily hospital-based organizations and academics. So they're going to be more that type of doctors and organizations. American Medical Group Association tends to be very large, multi-specialty groups, and oftentimes lots of HMO and things like that. And there are a lot of the Southern California large medical groups belong to AMGA. And then Medical Group Management Association tends to be everything from small private practices all the way up to large practices. So it's a real, conglomeration of a lot of different participants. And the two ones that you want to get a hold of are the Physician Compensation Report and the Cost Survey Report. And the data dive is really user-friendly, and you can go in there and slice and dice the data so many different ways. So that's what I use all the time. So you want to look and see how your practice ratios compare to the norms. And you want always your profit loss report with a column for each line item expense to be divided into the total collection. So there should be always a percent to collections for every single line item. And other than drugs, which, your chemotherapy drugs are your biggest line item. But other than that, staff and rent are the two largest expense categories. So you always want to pay attention to those. And just for some of the smaller practices in the group, if you're a sole proprietor, your profit loss is going to be organized like this with the revenues on the top. Each one of the line item expenses are going to be like this, which I want you to translate it in as divide each one of those into the revenue. So you get a percent to revenue, and then your total expenses into the revenue. And that's what you get for your total overhead ratio. And what's left over is the doctor's net income. That's how a sole proprietor or a partnership profit loss is organized. If you're a corporation, you're going to have the revenue on the top. You're going to have all the line item expenses, but you're going to have officer wages. The shareholder wages are going to be a part of this. Sometimes they're on the bottom, which I like better. But in any case, if you take out the officer wages and subtract it from the total expenses, you're going to get the 66.6 expense ratio, because at the end of the day, you don't want to have a lot of profit left over. So it's basically the same thing. It's just organized a different way. That's all. But that's the differences between the two profit loss reports. So let's look at some benchmark comparisons for hematology oncology. And this is the latest data. And remember, it's always a year behind. So the reports come out generally May through August, September, and it's always a year behind in terms of the survey data. So the ones that you want to pay attention to, charges are meaningless because you can set your charges anywhere. You can set your charges 150% to Medicare or 400% to Medicare. So I don't really even look at charges. I like to see what collections or revenue is, and then in all the different all the way from 25% up to 90th percentile, and then what the net income or compensation is. Now, this is what's fascinating. This is what's happened in your specialty, is that because there's been so much hospital subsidy and private equity subsidy of your specialty and academics subsidy, the collections now are oftentimes very close to or more than the net incomes, which is, when I started doing this a long time ago, it was always the collections were way more, but that's not true anymore. So generally you want to really pay attention to the median compensation when you're negotiating things, because when we get into compensation, most of the hospitals and foundations and academic organizations really are looking at median compensation. And we'll talk about that a little bit more in the later parts of this. But I really, really believe that all of you should benchmark your physicians every single year. Do a little benchmark comparison and show them where they are in terms of the money that they're bringing in, their collections, their productivity in terms of work RVUs, and then their compensation. And I can tell you over and over again that MGMA and everyone has shown there is a direct correlation between physician productivity and physician net income. So I always tell my doctors, I go, if you want to be in the 75th percentile of net income, this is what you have to do. You have to be in the 75th percentile of productivity. And I was talking about this yesterday when I was teaching another webinar, and I said, I sat down with a doctor and she wanted to spend time with her kids, and she also likes to spend a lot of time with her patients, but she was blaming the administrator that it has to be the administrators not managing the expenses correctly. And I looked at her and I looked at her and she's in the 25th percentile of productivity. So I sat down with her and I said, okay, option C is what you're doing right now. And you like to spend time with your patients, and you also want to spend time with your kids. But here's what can happen if you do option A and option B. If we add another hour to your schedule each day, you can see X amount of patients per year. And that I went through the whole charges and then what means with collections and the expenses and all the way down. And that's what it would do to change her net income. And then I also showed her option B. What if you just speed up a little bit and work the same amount of hours, but maybe just not spend quite as much time with each patient, and went through the same, math. So I showed her option A, option B, option C, and I said, it's your choice. What would you like to do? And she looked at them and she said, no, it's not that much difference in income. I guess I'll just keep doing what I'm doing. But now she's not mad at the administrator, and that's a win for the administrator for sure. But you have to do that with physicians because they don't understand. And it's too easy sometimes to just say, oh, it can't be my fault, or can't be my work productivity. It's got to be your fault. So you have to do this. You have to benchmark them, and you have to show them where they are. And large organizations will do that. So I really feel that you need to do that as well. Okay, so I like this visual about we don't want to see your hard-earned money go down the drain through, management issues. And one of the biggest things always is making sure that charge capture is being done correctly. So charge capture and billing is really important. So I just like this visual because I always thought it was really great. Are your practice expenses under control? And I don't want to see it, in the 19%. Some are, but some ones like staffing, rent, and insurance seem to have a life of their own. No, I don't want that. I want you to be in this category. Yes, I'm attentive to every penny my practice spends. That's our goal. So this is the latest MGMA survey for your specialty, and this is what I'm talking about. I want you to know what your norms are for your specialty, about what your peers are spending as a percent to revenue on staff and benefits and things like that. Now, remember this, in California, we always have higher expense ratios than national norms. So there's not as much data on Western region as there is, for national data. So you can pretty much take whatever national data is out there and add anywhere from 3 to sometimes 5 percentage points for the staffing ratio, and for the rent ratio, maybe 3% or so more onto the rent ratio, because we have higher staffing and we have higher rent costs. So in general, we will probably have at least a 5% higher expense ratio than national norms. And that's the way it is in California, because we have, especially in high cost areas all along the coast, all the coastal areas in California, higher costs than the inland region. So it depends on where you are in California, that's for sure. But at least you can use that as a benchmark. So what I like, I've always liked this visual because I don't think you should be sharing your doctor's net income with your staff, and maybe not even the revenue. But certainly it is appropriate for you to be talking about expenses and how they might be going up and how the staff can help, try to do something about that. So I really like to set contests for the staff on whoever has the best idea each quarter that makes or saves the practice money. And, that will get them energized, and they should have maybe it's a $50 gift certificate to something or other. And the idea should either make or save more than the $50. And that is a really good way. And they get recognition, and it gets them thinking instead of just doing their job. So do that. And I really, I love this with, actually it was a pediatric practice, and the person, they charge all their vaccines, which you can charge your chemotherapy drugs on credit cards and get the miles. And the person, they try to charge their vaccines on the credit card. And instead of the doctors taking all the miles for their airline trips, the person with the best idea for the year got an airline trip. And she was thrilled, absolutely thrilled that she got a free airline trip. So spread that around, and don't give it all to the doctors. Let the staff share in that. So it's just a visual to see that, because you know what? It's the best ideas cultivate decision-making and ideas from the bottom up, not the top down, but the bottom up. And I think that's important. So productivity, I really like you to keep track of all the doctors' productivity. And that is things like the number of patients that they see, the number of new patients to measure practice growth, particularly for new doctors that are coming into the practice. You should be tracking the new patients that they're seeing. And I always tell my doctors, if they have a new doctor into the practice, one of their goals is to become a partner, is that they should set quarterly marketing goals for that doctor to say, what are you doing to go out there and build your practice? I want to see you submit a list of all the things that you've been doing, not just expecting to sit there and let us do it, but are you going out and doing talks? Are you going out and meeting some of the new doctors? Are you giving grand rounds? Are you talking on the radio or anything that's news breaking about your specialty? They should be offering themselves as a media expert. All those things, they need to show that they are interested in building the practice reputation and their own practice as well. So number of office and hospital visits, number of procedures or high revenue generation, and of course the income generated by doctor, and work RVUs now too. That's very important. So you should be setting a productivity budget for your doctors. I really feel that now, in October, November is the best time to have a strategic planning retreat with your physicians. And you should be talking about, you should be doing an anticipatory budget for all of your doctors for a revenue and expense and productivity. And so then you can set a monthly budget and then record what actually happened. And then, do this on a year-to-date and year-to-date actual. So then it gets to be June of next year, and you can look at this budget and say, hey, Dr. So-and-so, you are really ahead of schedule. Congratulations. You can take that extra week of vacation. Or Dr. B, you're really behind. Is that maybe you don't want to take that extra week of vacation. You really need to crank it up a little bit. And that's what a good administrator is, kind of looking at all this data and trying to counsel your physicians on their productivity. So it's about data and it's about measuring things. Okay, I just attended a webinar this morning, and I added this in, and Nicole, let me add it in really quickly. And I wasn't able to squeeze in what the study came from. It's McKinsey and Company, and it was The Storm is Coming, Transformation by McKinsey and Company. You can Google and get the study. But I was horrified to see that, the labor costs are really high, and look at how they're continuing to expected to go up. So, clinical labor, wage inflation, and it got cut off a little bit. Operating margins and profitability, that's going to continue to outpace CMS and commercial rate increases, thus putting pressure on operating margins and profitability. So I was not happy to see this morning. So I felt like I had to stick this in here in the last minute, just so you were aware. And so then that goes into your budgeting and looking about like, what are we going to do? You know, we've got to either increase revenue, increase productivity, look to other ways to save on costs, maybe merging. I don't know what it is, but you know, if our wages are going to continue to go up and maybe our rent, what are we going to do? We've got to do something to continue to have our doctors be profitable and have the net incomes that they want. Okay, so reducing our staffing costs. Absolutely have good, excellent job descriptions with accountabilities, and especially for your billing people. That is so easy to do by having your accounts receivable ratios and where they should be and achieving MGMA or your association accounts receivable ratios or better. They should always be held accountable to that, the billing staff. Absolutely. You can use things like interns, college students, med students for scribes. They are less expensive and they do a great job, and they want to get that recommendation to get into medical school. So we've had a lot of success. I know here, you know, up here in Northern California, UC Berkeley, UCSF, a lot of my doctors in those areas use college students, and they're smart, they're bright, and they're motivated, and they love scribing. So, and this is where I got ahead of myself. They use the incentives to reward staff to make or save the practice money. So we talked a little bit about percent to revenue for staff or for all overall expenses, but you need to do this also for your staffing. And you should also be analyzing what your total staff payroll by position as a percent to revenue, and what your FTEs or full-time staff ratio to physicians. And it really varies by specialty. So this is MGMA data for your specialty. And, you know, they don't have, not all the positions they didn't have enough data for, but at least you can see that the FTEs or full-time equivalents per physician were about 3.65. You know, and you have a lot of registered nurses, which really ups your costs a lot. But, you know, will give you some idea about what your peers, how many full-time equivalents per physician your peers are, you know, having to employ to do your job for your practice. So that's one measurement. And then the other is, what are you spending on these wages as a percent to revenue? And like I said, the FTEs should be pretty similar nationally, but what you're spending on them are going to be a little higher. So like I said, in California, especially Southern California and along the coast. So it's going to be a little higher, but this is just giving you a general. So if the total staff wage is 24.33 nationally, I would say it's going to be 27, 28, maybe even 29% in California. But that'll give you some basic data to look at and see how you compare. So you should be doing this analysis. So this is an example only. It's not oncology, but this is what I do when I go in and analyze a practice. And this is what you should be doing. You should be looking at all of the different positions, how many doctors or NPs or you know, whatever you have in there, and looking at how many hours they're working and what the FTE is, and then dividing it by the providers that you have, so you can get the FTEs per provider, and then you can benchmark it and see where you are. And I use red for overstaffed and blue for understaffed, and I do it for both measurements, you know, for FTEs and payroll to gross. So I go right down the line and look at this and say, okay, then, you know, I can see what's going on here. So, you know, these people might be a little overstaffed in the administrative stuff, I'd say, and then, you know, maybe a little understaffed in the front desk and the, you know, the medical assistants type thing. So maybe they need to, this will give you ammunition to say, we're really understaffed with this compared to our peers. We need to maybe really need to hire some of these other people. And then, you know, again, you need to think about billing service. You know, this will give you some comparisons to be able to say, if I'm using an outside billing service versus what my peers are doing it internally, maybe I should do a cost benefit analysis about what I could do internally if I have a good labor pool. It's all about that versus what it costs to do a billing service. So, you know, this is what I like to see you doing, an analysis of your practice to see really where your issues are. I can tell a lot about a practice even before I go in. And, you know, you can tell a lot about it. So make sure everybody mutes themselves thank you, until the end. And then I'll take questions and we can unmute. Okay, so, again, benefits. This is an older survey, but it's still pretty much the same thing. What does everybody offer? Nothing's changed for this. And you really have to look at matching your benefits to what everybody else is doing in your area and so forth. So I would say talk to your local medical society, find out what everybody's offering in terms of benefits, because we have to compete with other, organizations. So make sure that you're doing that. So, whoops. Okay. Again, I talked about accounts receivable. You do need to know what your ratios are. And the billing service or the billing staff, you should incentivize them or penalize them. This is just a joke. That's for surgeons, but I think it's kind of funny. So I'll blow by that. You can look at that. Okay. So oncology. This is what the latest data shows about in what you should have in your buckets. And, this is the percentage of your total, and they don't add up completely to 100% because it's about the survey data. But I think this is kind of high. And I like to see no more than about 20 to 25% in the 120 days and over. So I really feel that this is reflective of a lot of hospital owned practices now and large private equity. I think when doctors did it themselves, it was a lot lower. And I see that. And every time I look at the data over the years, the more owned, the worse the ratios get. Larger billing services, they don't do as good a job. We know that, the older it gets, the likelihood of collecting it goes down. So no surprise there. Okay, so your gross collection percentage, again, it's fairly meaningless, but I just put it in there because a lot of times billing services only give you this ratio, and it's meaningless because it's a function of where you set your charges. But this was the MG. So if you set your charges really, really high, it's going to be low ratio. If you set your charges at 150% of Medicare, it's going to be closer to 100%. So it's a fairly meaningless ratio. This is the performance measurement ratio, because this is the performance measurement of the billing effort. So it's not actual to actual, it's over time. So it's real money collected divided by billed charges minus contractual adjustments. And it should be always 95% or higher. Okay. Other specialties are in the high 98, 99, but yours is a little bit lower, but it's within norms that it should be 95% or better. In other words, you should be collecting darn close to 100% of what you have agreed to accept contractually by your contracts. So, and you have to look at this, and you have to load your contract rates into your billing software, and your billers need to toggle or know what those are. And they have to fight for it. They have to appeal and go after that, because the insurance companies, the CMA and the AMA have done studies on that. And they found that they purposely do not pay you your legal contract rate, which is ridiculous. So it's buyer beware, and you have to hold them accountable for that. Okay, your turnover ratio is your total balance of accounts receivable divided by about 1 month of annual billed fees or charges. So it should be around 1 month is all you should be carrying in your accounts receivable balance. And I like to even see a little bit less than that, but that's not bad. About 1 month is about right. So that's good. And it shouldn't be more than that. If you've got 3 or 4, there's something wrong. That's not good. So hold them accountable to that, and make sure staff has time to do that. Do payment plans. You should be making collection calls. You should, actually say, make calls and say, we notice that you have a balance. Is there any reason why you haven't paid our bill? And wait. They have to say something. So it's either going to be the check's in the mail. So you can say, well, I'll be calling you in 2 weeks and we'll follow up on that. I never got the bill. Well, let's see if we've got the right address, blah, blah, blah. Well, I'll be calling you back. I'm having financial problems. Let's work out a payment plan. We can do that. Or the other reason we know is that they're not happy, and they're choosing to display their unhappiness by not paying the bill. So when you call them, you can get to the root of the problem and try to solve that so you can get paid. So you got to make those collection calls. It's very important. And care credit, whatever you need to do, and use collection agents or agencies, very important. So make front and back a billing team, have them guest visit and shadow each other. They never understand what the other one does. And that is a big deal. So make sure that when they come on board, that they spend time with each other so they truly understand each other's job, and it reduces errors. So that's really, really important to do. And I want to see if at the end, if everybody else has been doing that with your front and billers. It's a good thing to do. And when you have staff team things, when you have team building events, make sure that the front and the billing people are in the same, mix them up and put them on teams together so they can get to know each other. Okay, so health savings accounts, have HSA debit cards, take debit and credit cards, and have good policies and make patients sign that they are receiving their rights and responsibilities. And that should be on your website too. You should always have things that say, here's our patient rights and patient responsibilities, two-way street. Okay, you also need to keep track of ambulatory encounters, and you should know what your data shows on this as well. So, national data as well as Western region data. So when we look at, the different median, our medians are a little lower in the Western region than the national. And that would be important to know if you're negotiating your contracts. So always look at, having access to the data. It's not a lot of sample size though, so that's the problem. But remember that most of the people that are negotiating contracts, they're going to be looking at the national data probably pretty much. But, you might want to try to negotiate. But this is what I mean talking about benchmarking your doctors. Figure out where they are on the scale of, are they at the mean, the 25th percentile, the median, the 75th, the 90th percentile in terms of their productivity. And, again, this is from Medscape, and, see how many hours a week they're spending seeing patients. Where do your doctors fall on that? I just thought I'd throw that in too. You can just Google the Medscape report too on your specialty, and you can get all that data too. Okay, so those of you that work for systems where your compensation is based on work RVUs, you really need to have this data, and you need to have it every single year, and you need to have national data, and you need to have Western region data. So I'm giving you this, and like I said, this cost me a lot of money to get this every year, but I'm happy to give it to you because I want you to have this data. So you need to know what the work RVUs are from the various ones, and you might be held to some of the contracts will average 3 sources of data. So they might do that. They might say, okay, let's average the median work RVUs for all 3 sources of data, and you'll be held to 3 sources of data for the median, okay? And then maybe we'll average the work RVUs for the median as well. But now, if you were going to be paid on a work RVU basis for bonuses, you sure want the MGMA data over the Sullivan-Cotter and the AMGA data because it's a higher dollar per work RVU. So you can use that to negotiate. But that's what you have to have is data. Data wins. It really does. So getting the data is what's going to be really important to you. So, and then again, you have to look at Western region data. So, look at that. I'll toggle back and forth. Western region data is, $109 versus $193 and $94. So if I were you, I'd be trying to negotiate for the Western region data for dollars per work RVU for both Sullivan-Cotter and MGMA Western region. So, again, this is what helps is when you have Western region data, and you just have to, have all this data at your fingertips when you're negotiating with hospital administrators, private equity, foundations, academic, whatever it may be, you come armed with data, really important. Okay, so compensation formulas. These are some of the tricks that I've seen, so be very careful about this. The organization expects you to achieve median productivity, but they use the 25th percentile level for your bonus for dollars per work RVU. I think that's really crappy. So make sure that you know if they want you to achieve median levels, that you get bonused at the median level for work RVUs. And this is something that I've seen a large hospital system in California do, and I thought it was really crappy. And I told them that. I told the hospital administrators that. They make the doctors sign their contract every April, knowing full well that the MGMA reports come out in May. So the data is already 1 year behind already. So when they make them sign their contract in April, they're using, for example, April of this year would be 2022 data based on 2021 information survey data, as opposed to waiting another month, which would be 2023 based on 22 data. So that's always 2 years behind. And I think that was really, I mean, I think it's unconscionable, quite frankly, but you know, I mean, once you're employed or basically employed by a foundation, it's really tough. So you got to know when your contracts are up for renewal and when the data surveys come out. Sometimes the contract requires you to supervise nurse practitioners and PAs. How much does that take away from your productivity? Do you get extra compensation for that or not? That's really important. So sometimes some contracts will give you extra money for doing that. Who compiles the data? Check it. When does it come out? Does it come out every month? Does it come out quarterly? I have seen so many of my doctors be very, very upset because they do not trust the data. They do not trust who's compiling it accurately. And they've actually gone to keeping track of their own productivity because they did not trust the system to do it accurately. And, you know, once distrust sets in, that's not good. So that's really important. I've seen contracts. It's not your specialty. I was looking at a urologist contract for things, and it actually said that the urologist was going to have to read EKGs, which showed me that they had not, they just used a template for a cardiology contract and just threw in that urologist's name and didn't bother to take out the section that said he would also be required to review EKGs. So there's a lot of mistakes in some of those contracts, and you have to read them very carefully. And then I think it's really important to argue that some of the median level, because the legal department always wants to go to the median level because they feel very safe with that they're not going to go over fair market compensation and get into trouble with Medicare. But that is ridiculous because that's usually national and not reflective of higher costs of living, Beverly Hills versus El Centro, for example. I mean, come on, that's just ridiculous. So you need to get the Forbes and all the different cost of living surveys and say, hey, our cost of living for housing and, you know, groceries and gas and everything else is much higher in these high cost of living areas. So therefore we should be at the 60th, 65, or maybe even close to the 75th percentile for compensation, especially when it's just salary level or dollars per work RVU or bonus of after the base salary, because they usually will set the base salary at 70 or 80% of whatever the median is, and the work RVUs at 70 or 80%. And that's your base salary and your base RVUs. And you get bonused up to the dollars per work RVU for anything over the base. So that's the way that these contracts usually go. But you have to understand that, and you have to have the data. It's critically important, very, very important. So this is just a joke. Have you been waiting long? That's the old joke with physicians. And, you know, your doctors have to understand that. And I know your specialty is very heartfelt and very difficult, and they need to spend time with their patients. And I totally understand that. And, but, you know, when your doctors come in late every day and then they run staff into overtime, you know, maybe if they stay on time, they can see another 2 or 3 patients a day, and they're not going to run staff into very, very costly overtime, which, as you know, in California, we have the either or, anything over 8 hours in one day or 40 hours in 1 week. So that can be very costly. And I actually put that in my shareholder agreements when I'm working with physicians, that if a doctor is consistently running staff into overtime because of their own behavior, like coming in late, and that kind of thing every day, that maybe they're going to have to pay for the overtime. It's not fair to the other doctors that they're paying for overtime when it's one doctor's behavior. So you might have to do that. So like I said, a budget is a financial plan of action and activity. Try to live within that budget. Use all of your other managers on how to use Excel. It's a very important skill to use. So like I said, do a budget for your productivity, do a budget for your income and your expenses, and look at your monthly budget, look at what happened actually, what it was a variance, the year to date, and then you can really learn to manage your practice on a more sophisticated way. And so I like to see the productivity of the doctors. And so you can see them on a quarterly basis and year to date of what's the difference between last year and this year. So you can, show that at their meetings and, the collections and see what's happening. Why are we under, what's going on? You need to be able to explain that to them. So, and I think you need to have a really simple flash sheet of all the things that we've been talking about today so that they can see it, they can learn, you teach them the ratios and you break it down really simply and show them, okay, this is Dr. A, B, and C. This is what the totals are. This was last year. Okay, so we just learned about the AR ratio, okay? This is what it was last year. This is what it was last month. This is what it is right now. Okay, that's a negative trend developing because it should be lower than 1.5. It should be 1.1 actually. So when they see that, the doctor should be saying, when this is what it would be, that's not your specialty, but if this is the MGMA ratio and it's here and it was here last month and it was this before, somebody should be saying, why is it that? And if the manager says it's just a monthly thing, we've got a couple billers out on maternity leave, it'll be back to normal, we'll get it down next month, there's an explanation. But if they look at you with a blank stare and say, I don't know why it's that high, that's a problem. Or if your billing service doesn't know, it's a problem. So it's the same thing with the, percentages in the buckets, so to speak, and the overhead percentage. So should be broken down into a very simple benchmark sheet so you can explain what's going on in your practice very quickly and simply to your doctors on a monthly basis. I really believe that. They should understand this and know it, and you have to educate them. And I tease my doctors all the time. This is simple math. And I kid them all the time, and you can kid them too. I said, you put a dollar sign in front of math and you all freak out like you don't understand it. You did way harder math than this to get into medical school. This is very simple. Look at those ratios I just showed you. Simple math. Don't freak out just because it has a dollar sign in it. And they laugh. So just be funny with them. I try to be really funny with my doctors, and they seem to understand it then better. Okay, so I mentioned about this, about there's a direct correlation in rating stars and waiting times. So if you want to get good rating stars on all your social media and your Google, ratings and so forth, then you really need to, do a good job with this and explain that to them. This is really important. So that's really important. So I can't change this, but I just remember that would be oncology. Some of your doctors think that all they were going to have to do was learn about oncology and internal medicine. And then they realize that they have to learn all the stuff that they never taught them in medical school. And, it's not that hard though. And I keep telling them it's really, really not that hard. So that's the most important thing. It's very simple. Financial ratios, benchmarking, and we'll take it for questions now. And I'm happy if you want to unmute yourself, or if you're shy, if you want to put it in the chat box, maybe Nicole can read them to me if you're shy. But I don't mind taking questions right from the audience. So if you want to unmute yourself, or you have any comments, anything, I'm here for you.
Thank you, Deborah, for presenting that information. Like she just said, feel free to type a question into the chat or unmute your line.
Don't be shy. And if I went too fast, sometimes I have a tendency to talk fast. So, and I know that.
Well, we will put Deborah's contact information in the chat, and then it will also be in the follow-up email in case anyone has any questions later on. You can contact her
I
directly.
think there's some stuff in the chat. Is that something else? I see some.
I actually can't see the chat. I mean, I can see that the chat.
Okay. Well, let me see. I think I
Christy,
can
can you
them.
read the chat?
Okay. It
Yes,
says
so she says, thank you, Deborah. Well done.
Yeah, a lot of thank you stuff. Okay, it's mostly thanks. Oh yeah, you're gonna get the PDF. So somebody's gonna send out the PDF of the slides, correct?
Yes, we will do
Yes. Is buy and bill dead? I don't know anything about that, so I'm really sorry. I can't answer that question. Maybe somebody else can. I'm assuming that's some legislative stuff about drugs.
Our next webinar on October 26th actually will be on bill.
Okay. All right. Well, that's good. So attend the next one then. That's important.
All right. Well, I don't see any questions coming in. Thank you again, Deborah, for presenting that information. We really appreciate it.
You're welcome, and have a good rest of the meeting.
Thank you so much.
Okay, I will sign off.
Okay, thank you.
Figure out how to do it here.
No,
stop share. Okay, I got to do that first. Okay. Oh, a lot more people are in there than I thought. Okay, bye-bye.
bye. All right, so now we're going to move on to a few announcements from our corporate sponsors. We'll go ahead and share their contact information in the chat as well in case you wish to contact them after the webinar. I'm pleased to introduce our first corporate sponsor, Hillary Zachary from Gilead. Hillary?
Hi, and I'm so glad I'm on. I was just on with my tech department because I didn't think I was on video, and then I looked up at the screen and I've been on your video and I just hung up on them. So it's a pleasure to be here. Thanks for taking the time. I know you guys are very busy administrators in your practices. So I'm the key account director for Gilead Oncology, and I'll just be really brief, but some of you may know Gilead from a HIV background, or in the liver space, which is where we have a huge footprint, but we are definitely in oncology now. And our product is called Trodelvy, sacituzumab, and we are indicated in both triple negative breast cancer and HR positive. And we are double downing on MOASC, and that's my responsibility. So I cover the whole Southwest region, and state societies are just a big part of what we are trying to increase our footprint with, because we are both academic and community based for the account director team. So I'm just really happy to be here and thrilled that actually all the technology is working, even though I was letting them have it. And I certainly welcome, questions. And I think my name just went in the chat from Christy. We have a robust reimbursement team that we work with, and we also do a lot of high-level partnerships with COA and I'm actually at ACCC as we speak in Austin, so that's where maybe if it's loud and that's what you're getting, but I'm just going to be brief, and I really am happy to be here and look forward to working with a lot of you now and in the future. So thank you.
Thank you so much, Hillary. Appreciate it.
Yeah, my pleasure.
We'll move on to our next corporate sponsor, Nicole from Insight. So I see you, but I think your line's muted. It will not let me unmute you. Interesting.
I know Nick is here, just so we're clear. I just met him yesterday on the escalator at ACCC. So Nick, hope to see you.
Looks like you're still muted. Okay. While you're doing that, Nick, I'm going to go to the next person and I'll come back to you. Okay, so we're going to skip ahead to Kelly Berry with Jazz Pharmaceuticals.
Hi, can you hear me?
Yes.
Hi, I am not at ACCC. I'm in my kitchen, but thank you so much for having us. I work for Jazz Oncology. I am in the access and reimbursement role. We do both access and reimbursement and GPO contracting and pull through in California and Hawaii. We are definitely committed to helping patients get access to our products. The 4 products that I currently represent are Zepzelca for small cell lung cancer, Vyxeos for acute myeloid leukemia, Defitelio for patients with VOD following transplant, and Rylaze for adult and pediatric patients who have developed hypersensitivity to asparaginase. And again, I know that you'll pass along, oh, there's my information. If you need anything regarding the Jazz portfolio, we are here to help.
Wonderful. Thank you so much. Did Nick make it back on? Oh, goodness. Okay, I don't see him. So in the interest of time, we will move on to our next speaker. I'm sure you all know her well, Dawn Holcomb. She is the president of DGH Consulting. She's going to discuss the specialty carve-out programs and what they mean for your patients. So without further delay, I'll turn it over to Dawn. Dawn, your line is also muted.
I'm just trying to share my screen.
Yeah.
Or do you have the ability to just show them and I'll just speak to them? What do you prefer?
Probably just share your screen if you could do that.
Share screen. Okay, are we up? Oh, yes, we are. There we are. Okay. Now just go to the slide view. Back to the opening. Okay, I think we're good.
Okay, go ahead.
I like to go to a regular slide view, but I'll take what I can get.
Hey, Christy. Hey, Christy. Nick is here. I'm just waiting to be readmitted to the Zoom.
Okay, I'm sorry about the next slide thing. I'm not going to delay anymore, trying to get it better. I'll stay with what I've got. Okay, I wish I could see everybody. Dawn Holcomb, and I love all the times that I get to work with MOASC. The alternative funding programs, and I called it alternative drug program. I should have said AFP. That's what we call them now. We also have called them specialty carve-out programs. And what I'd love to do is ask who's familiar with them, because it is something that is growing in awareness, but not everybody yet has run into them. So since I can't see you, I'll just assume that there's a mix in the audience of who has seen them and run into them and who has not. So what we're going to look is we're going to talk about these alternative funding programs. And what they basically are is a mechanism for separating out certain patients for employer health benefit plans. And those patients usually have higher cost specialty drugs. And when they have the treatment or have the diagnosis with a drug that's on their list, they then tell the patients that they're not covered. And then this alternative funding program will seek alternative sources to pay for the drug so the employer does not have to. And they usually will provide zero copay for the patient to make it attractive to them. There's a lot of pros, there's a lot of cons, more cons than pros. And we're going to walk through what is this program? How would you know it if you see it? Who are the players that you may hear about, although sometimes they change their name? What are the consequences of it? And then what might be your plan of action for changing or dealing with them? So first thing is, why would a self-insured employer be interested in this as part of their benefit design? Well, the reason is that self-insured employers are afraid of the cost of drugs. Specialty medicines are almost half of their drug spend, and about 35% of that half are in medical benefits, the other half. They're very worried. And I have a lot of information on my slides. I never speak to all of it. It's there as a reference for you. When you get the slides, feel free to look through them and contact me afterwards if there's more information than you need. I'd rather give you more information than I can speak to than have you walk away saying, "Ooh, I wonder what she really meant by that." Sorry, I'm trying to get over to the arrow. So there is a National Alliance of Healthcare Purchasers Coalitions, NAHPC, and they are very vocal within their clients who are self-insured and large employers. This is a two-page document that they have put out about how they are going to help their members and how their members can target high-cost drug claims. Now, I'm not going to read all of this to you, but I will call out to you that they estimate that just 1.2% of all health plan members are high-cost claimants, but they make up about a third of the total healthcare spending. So it is attractive to an employer if they can find a program that deals only with a little bit more than 1% of their employee population, but can have a significant impact on their spend. The backside of that, this two-pager, and I have the link for it down in the bottom in the slides if you want to go to it, is that they are trying to be very proactive in how they're reducing drug costs. Sorry, I'm working at the end of a sinus infection. They're very proactive. They're changing their contracting strategies. They're looking at saving strategies, getting targeted vendors to help them work with these costs. So one of their alternatives is to look at these alternative funding programs. So where are these alternative funds that these vendors tell the employers are available to cover the cost of the drug so the employer does not have to? Well, they come from manufacturer-free drug and copay assistance programs, foundations, patient advocacy, brown bag or white bag drugs from a specialty pharmacy that may not be the provider that the patient is receiving care from, or they can be imported foreign drug from Canada and overseas. Commonly, I see India and Australia pop up besides Canada, and there may be other sources, but these are the primary ones that they're focused on. Are you going to see these in your practice? Maybe not, because these vendors contract directly with the employers. They're recommended by brokers as a cost-saving mechanism. They don't have to talk to the doctor at all. They contact patients directly to enroll in the program, and they have the patients sign over their medical financial information and other details, including prescriptions and copies of their photo ID, their driver's license. Very important to know that. And the patients just may come to the doctors and tell you, I'm not covered for this drug, or I have to receive this drug from another source or face penalties. And I'd love to be seeing people in the room to see how familiar you are or how many may have run into this. This is a graph I put together to help physicians understand and physician practices why they probably may not hear about these. They'll see the after effects, but they may not know that they're going on up front because the broker is contracting with a self-insured employer, and they're also contracting with the alternative funding vendor, or the AFP program. And then it's when the patient is seen and has a prescription, and this is often for orals. So this is where the AFP will jump right in, and the AFP the patient will be told you're not covered for that drug. They're usually told that by the PBM, which may or may not be in league with the alternative funding vendor. And then the alternative funding vendor talks to the patient, tries to see if they can get funding elsewhere. And funding means somebody else to pay for the drug so the employer does not have to. And if they can get somebody else to pay for the drug or have it at reduced cost, they can afford to give it to the patient at no copay. The patient is either confused or happy because they have no copay. They're very vulnerable, but they may think that they're being taken care of. But they also will probably have decreased access to support around the drug because it's coming from some third party. And the only activity that this vendor has is to get the drug in the hands of the patient. They're not doing any support for the patient. They're not there when the patient has a question. All risk of adverse events goes to the physician and to the patient, and all risk of exposure to imported drugs goes to the physician and the patient. The physician is down in the bottom of the corner here, may learn that the patient doesn't have coverage or has been recovered because they were dumped out and now they're dumped back in, or just be told that they're getting the drug from another source with no alternative offered for the physician. And what are the issues of these programs? Well, one of the big issues is the reason they can do this is they have declared to the employer that although prescription drugs are protected under the ACA as an essential health benefit, that they have decided that certain drugs are not essential. And though it could be decided based on price, it could be decided based on disease, it could be just decided on the fact that, well, if you got this other drug, there's not a really good free drug program. So we want you to have this drug. So we'll put the one without the free drug program on the non-essential list so that we can then refer you to the one that has a better program where we can likely get the drug for free for you. A lot of gamesmanship going on here. They will tell the employer that they can get alternative sources, but they're not telling them where the source is coming from, whether the discounted price or whether it's the free drug. They claim that there's only a small percentage of the employees that are affected, so it would be easy for them to give the employer a really big impact with a very little small effect on employees. We'll talk about how that plays out in reality when you are one of the employees. What this does is it increases the demand on the patient assistance programs, free drug, the charity, the foundations. They already have limited resources. And as I've described this, and I think I have a slide referencing it, but I was talking to a reporter and they were trying to document these programs. And, why isn't this a great thing? And I was thinking on the fly, trying to think, well, how can I put this in terms that she as a layperson would understand our concerns with this? And I hit on the idea of soup kitchens because everybody knows what a soup kitchen is. The soup and the food is there for the people who truly need it. And other people donate their time and their resources so that the soup kitchens can stay open and be available for those that need it. This is the equivalent of the alternative funding vendor pulling a bus up to the employer, helping the employer tell their employees that they are now no longer covered for a drug, so they're now not insured. So they fall in the category of being needy, load up the bus with these otherwise employed, insured people, drive them up to the soup kitchen and drain the soup kitchen so there's nothing left for anybody else. That's the problem that we have here. And I also am very concerned about the wholesale importation of drugs coming in from the US. There's no pedigree, there's no liability for any of the medical issues that come up as a result from that. And one of the biggest issues here is that this is a program that has inserted itself into the stream of healthcare delivery where it really wasn't needed. Medical practices get patients on these programs when they need them and when they qualify. These folks are trying to create a category of employee that will qualify because they're artificially telling them that they are not covered under the insurance for which they think they're paying as an employee of Acme employer. So we've got confused patients, a whole lot of missed messaging going on. Here's just the background slide about the non-essential benefit declaration. This tells you the link to the Patient and Protection and Affordable Care Act, where the essential benefits, health benefits are defined, and prescription drugs are defined as one of the 10 essential health benefits. The purpose of these vendors declaring these drugs that are prescription drugs to not be essential is that it then gives them the ability to flip around the categories of copay, deductible, consumer out-of-pocket costs. And you'll see how they do that in a little bit. Actually, the vendor will usually charge, if you do not sign up with these vendors, the stick is that patients are told you either you try to get this non-covered drug through this vendor, or you are 100% on the hook for the cost of the drug, and it will not apply to your deductibles or your copays. And these are sometimes very pricey drugs. So that is an incredible stick that forces the employees to feel like they have to sign up with these alternative funding programs. There's hope on the horizon. Not a lot of employers are really looking at this seriously yet, but about 20 years ago, we had retirement benefits, that employees had retirement funds, the employers were responsible for handling their retirement benefits. But it was a little bit about the wild, wild west. There were fees that were charged that were just undefensible. Nobody knew exactly what was happening with the management of the retirement monies. People never even knew for sure if their monies were going to be there when they needed them. And the government stepped in, and that's when they passed ERISA. And one of the aspects of ERISA was to put accountability on the employers for being responsible for how they handled their employees' benefit retirement accounts. The same thing has happened now in 2021. The Consolidated Appropriations Act, if you haven't heard of it, it's usually called the CAA, and it put protections in place for consumers about surprise billing and transparency in healthcare. Buried in that act, in just a few pages of the hundreds and hundreds of pages in the act, is relevance that tells self-insured employees that they are required to ensure that their group health plan is cost effective, offers quality of care, and offers, they are responsible to their employees for the value of the care and the decisions and the vendors that they're choosing to manage those health benefits. That may be the hook that we can use, because we're already starting. We saw lawsuits popping up on the retirement benefit accounts where people were suing their employers, class action lawsuits, for how their retirement benefits were being mishandled. We may well see, and are already starting to see, the start of employees going after their own employers saying, I'm paying premiums for health benefit and what I'm getting doesn't make sense. So we'll go into that in a little bit more. So who are these players and what is their pitch? I have information in here. I'm not going to go through it in detail, and I'm just watching my time as well. There are several. There could be as many as 20, and they keep changing their names and popping up. I pulled 9, 1, 2, 3, 4, 5, 6, 7, 9, and I'm giving you more detailed information on them so that you can try to get an awareness of what might be popping up. These are third-party vendors. On this slide, you have their names, you have their website, and you have what they call themselves: a prescription advocate, an advocacy service, a consulting company, a plan participant focused cost saving service. If you were to Google alternative funding vendor or program, you may or may not get access to all this information because they're not calling themselves that. We call them that when we're trying to describe them. So script sourcing, and then there are others. So what I'm going to do now is go through each one of those and give you a little idea about where they're based, what their pitch is, and then what some of their savings that they're promising to employers or pretending to employers that they have, and then what maybe sometimes what are their contract terms. Because it's important to understand what they're saying and what they're promising before you can figure out how you're going to approach them. So Impact RX is based out of Boca Raton, Florida. They call themselves an alternative distribution channel to help individuals qualify for their MUM, which is Medication Utilization Management, I believe is the acronym. They promise no more copays for qualifying employees. And they ship the drugs, either white bagged or brown bagged, they ship to the home or to the doctor's office. And once the employer engages with their Impact's MUM program, the employee has to participate in the process. It's mandatory. And they have to provide all the documentation and and information to Impact RX so they can use their benefits. Now, the savings, they're offering only 28 employees use their services out of 370 in one hospital in California. So you've got hospitals that are clients of these alternative funding vendors. And I'm not sure they even realize how they're hurting their own delivery services or physician services. There are 17 high-cost specialty medications, and they claim $622,000 in savings to date. In Pennsylvania, there was a charter school. They only had 15 employees that had to be covered under the program out of 418, and they claimed almost $700,000 savings to date. Another one is called Paid Health. It's out of Dallas, Texas. And what I have bolded here are particular items that you may want to pay attention to. In this case, this is their process. The health plan will deny the drug after you've prescribed it. They'll send it to Paid Health. A letter and an FAQ is sent to the employee. The employee has 30 days to complete the application. Now, this is all creating delays in care, including they're asking for household sizes and income. And then they'll sometimes use drug cards in the interim. If approved, then the patient will receive their free drug from the manufacturer, or usually for 6 months to a year. And if there's only partial funding approved, they process the drug through the specialty pharmacy, which is Magellan in this case. And again, there's zero copay. But if the patient doesn't qualify, they say, "Oh, sorry, we tried." And then they'll tell the patient, "We have processed a special exception for you. Now we are going to cover you under your normal insurance plan with whatever your normal copay is." So then they go back into the normal insurance plan that they thought they were paying for anyway, at say a 20% copay, and they're on the hook now because they didn't get approved for special assistance. And if they needed it, I had a patient reach out to me. I've written 4 editorials about these programs in oncology practice management. You may see my editorials. I'm the editor-in-chief, so I get to do something on what I think we need to worry about or what's going on. And these, since December 21, I've done 4. And every now and then, patients will call me directly and say, "I read your article. What you said they were going to do, they did, and now I just got put back into the program. But I just had my assistance denied, and that was assistance I was getting for the last 3 years. So now I'm stuck with a 20% copay, and the cost of my drug is more than my mortgage. Without assistance, I can't take this drug." And they're desperate. They don't know what to do. So it's not necessarily an asset that these folks have pulled them from their normal insurance, made them feel for a month or more that they weren't covered. They were desperate. They were trying to find, and maybe there was this wonderful free drug on the horizon. Then it doesn't happen, and then they get dumped back. And the patients are going through a horrible, horrible mental stress period just because of what these programs are doing. Paid Health has what they're telling their employers, their clients. We market to self-funded, to group health plans, municipal, and Taft-Hartley. And we are focused on finding funding solutions to the self-funded market for health and welfare. If you're a group and you want to take back control of your costs, you can rely on us to help meet your financial and your service goals. Now, most employers will look at what they spent last year. They'll look at what their actuaries are projecting that they will spend next year, and then they look to their brokers to help them figure out how they're going to mitigate those costs. That's why these programs often come through brokers. They're not asking the physicians, "Does this make sense?" It's purely a cost, and they're being promised that this is free drug coming, it's readily available, you're not hurting anybody, and your patient's going to get no copay. It sounds wonderful. Their messaging, Paid Health messaging to the client, has changed the conversation. And I've given you a link to a blog posting that tells you exactly what their terms are. And they're pretty much the same as I've told you. So you can read that if you want to see more about their message. Now, you are not going to be able to read this slide, and you won't even be able to read this slide when it comes to the slide. But I have the link to it. And what I want you to do is take a look at 1, 2, 3 pages of drugs that Paid Health has decided are non-essential. Now, they're not just for oncology, they're cardiology, they're rheumatology, they're sickle cell anemia, they're other rare drugs, anything that they think is going to be they're going to be able to get it from the manufacturer or overseas at a reduced price or get some kind of other help. I was able to dig deep, and I found some of the contracts that they have with their employers. And this one is interesting because it came out of a Tennessee contract. And as you can see in the middle, the customer, the employer, needs to tell its claim processor to adjudicate all claims and send everything on that drug list directly to Paid Health. And yet this one does say at the bottom that the program enrollee healthcare doctor shall have the final authority over what is prescribed. So if you happen to find someone that has Paid Health and they want to get do some kind of a non-medical switching on a drug, you may have the ability to say, no, this is the drug that I want my patient to get for these reasons, and this program is not going to be working for them. More details. This is just to show you what they tell their clients, that they're going to take in all the enrollment information. They're going to collect all the information so that they can do what they need to do, which often means representing themselves as the employee or as the patient to an advocacy group or to the manufacturer assistance program. Then they also say down at the bottom, you may wonder, how do they get their money? They get their money if they have been able to obtain, for instance, a free drug from a manufacturer. They then charge the employer client, sometimes usually between 25 and 33% of the average wholesale price of the drug. So not what the insurance would have been, not what the contracted rate, not what the net of rebate would have been. It's the full wholesale price. And that's the second paragraph down here. They're basing their prices on First Data Bank and such pricing. So they're actually basing their fees on a higher rate than the employer probably would have paid anyway. Payer Matrix is out of Media, Pennsylvania. This is a very common one. You may hear a lot about it. According to one website, their estimated revenue is almost $15 million. They do appear to be aligned with Express Scripts Pharmacy, so that means they may be aligned backward with health plans. They actually have won, and they were an Innovation Summit winner at the Purchasers Group on Health First Summit in 2021. Employers love these programs. I went to an employer-based program in Florida, which was the best of the best programs that we are finding to deal with our drug costs and our health benefits. And 3/4 of those who were presenting were standing up at the podium saying, these alternative funding sources are the best things since sliced bread. I don't have to pay for the drug that I used to have to pay under my health benefits. And even I myself, as the VP of HR, I'm now getting my prescription drugs shipped to me from Australia. They come every 5 to 7 weeks, and I don't have to pay a copay. And my employer pays half of what they would have paid if they were buying them in the United States. And it's funny it's sad actually to see how much the employers think these programs are giving them a good return and good value. Payer Matrix happens to collect 30% of savings. And there was an interesting battle going on in 2019 in New York between the City Transit Union and the Metropolitan Transit Authority of New York. Each accused the other in various different documents of bringing Payer Matrix in for discussions. But then the Transportation Authority called out the union boss for bringing this specialty drug scam program in. And then they called Payer Matrix racially discriminatory because it excludes drugs for chronic diseases like sickle cell anemia. And at the time, Payer Matrix was projecting savings for this group of $50 million, but it was only for US citizens, not for the hundreds of union members that were not yet citizens. So I don't know what happened if they ever end up contracting with them, but it was really fun to watch the dialogue going on between them. This was an announcement that a union that was using Payer Matrix sent out to its employees, and they were replacing a PBM called Evergreen Pillar RX. And they're telling the employees, we're doing this so that your copay will be fully covered. And by the way, if we can't get it covered, we'll put you back in your normal insurance. So it's a very common theme. For Payer Matrix, this is their drug list. 1, 2, 3 pages again of drugs that they have excluded. There are oncology drugs in here. And these you will be able to, I can see Perjeta, Rituxan, Herceptin, on this page alone, Velcade, Avastin, Rubrica, Ibrance, just a number of, that's only on the 3rd page. So as you can see, these are drugs that you're going to be running into on a regular basis. In California, I was able to dig that Shamrock Foods uses them for their specialty cost drug management. Also, the United Food and Commercial Workers National Health and Welfare Fund has their what they call a specialty drug cost avoidance program. They are using Payer Matrix. I gave you a link to the PDF about that and the information that they're announcing. Blue Cross Blue Shield of California has just announced in August a 4-point PBM revolution plan. And they're not going with their normal PBM. They're using choices of different PBMs. One of them is MPI-RX. MPI-RX uses Payer Matrix to do their specialty drug carve-outs. So you've got the link there. You'll be able to take a look at it. So you may see this coming in from your Blue Cross Blue Shield of California patients, not a small payer. And I gave you another link to where MPI-RX says very upfront that we use Payer Matrix for our high-cost specialty medicines. And oh shoot, I spelled his name, Michael Jordan. I misspelled his name. That should be CH, not K. But there's a YouTube here where he's being interviewed by a union labor network about the advantages of this program and what they bring to union members. It may be very interesting for you to look at that, because after I've been doing a number of talks about these programs, and next thing I know, I just finished one, and about a half an hour later, Michael Jordan asked to connect with me on LinkedIn. And he said, I'd love to talk with you so we can explain what these programs really are. And I'm sitting to myself and I'm saying, okay, I'm dying to hear, because I'll always listen first, but I'm dying to hear their explanation as to why they tell people that their prescription drugs are not needed and then only provide them services if they can get the drugs for free. Otherwise, they dump them back into the normal mix again. There's a little history further on. There are 2 lawsuits in play right now about these programs. One, thank you very much, Johnson & Johnson, is suing Scripps, Save on SP, and for misleading and misleading patients and draining and misrepresenting in a fraudulent basis these patients so that they can drain the free drug program, among other challenges. AbbVie is suing Payer Matrix. Payer Matrix, as soon as the lawsuit dropped, put an article out in the press, and I have a link to it later on for you, that said, leading patient advocate decries AbbVie for denying needy patients their drugs. And the backlash that happened from the patient advocacy community was really interesting, because clearly these alternative funding programs are not patient advocacy programs. They're actually hurting patients. They're there for their own self-profit. And there were 34 advocacy groups representing 14 disease communities that wrote a letter to Payer Matrix, and it came from Cancer Care and the National Bleeding Disorders Foundation in August. And I gave you a link to the letter here. And what they're basically saying is that patient advocacy groups are organizations that represent, support, and advocate patients, and that we're usually nonprofit organizations. Payer Matrix is not that type of organization. In fact, Payer Matrix profits each time it enrolls a patient in a patient assistance program. As such, we believe it's highly inappropriate and misleading for consumers for Payer Matrix to classify itself either as patient advocacy or as a patient advocate. I thought that was wonderful. And they also commented that these programs are already available to patients without a single iota of effort from Payer Matrix. And so some of these comments in here may be very useful to other organizations or even practices if they want to, when you are ready to go to employers or to patients and help them understand how they themselves could challenge these programs. Look at my time. Nicole, should I be still going to the bottom of the hour?
Sure, that's fine.
Okay, good. RX Free for Me is in the Detroit area, and I used to live in Ann Arbor. If you've ever been in or near Detroit, you know how close it is to Canada. It's just across the bridge. So RX Free for Me promises that they can save up to 75% of drugs, but most of the drugs are dispensed domestically and from Canada. So What's very interesting is in some of their contract language, when they're talking to patients, they they explain that there are going to be shipping delays. They also explain that delivery has to be signed for. So somebody has to be in at the house to accept the drug. They also say very clearly that the prescription can't be altered in any way, nor can it be filled prior to submission to RX Free for Me. And the patient needs to contact the physician if they have any unexpected side effects from the medications ordered from RX Free for Me. So if it comes in adulterated, mishandled in shipping, or just a very bad copy of a drug, it's the fault of the physician to help the patient get through that, even though the physician never ordered the patient. Now, we all know that physicians are liable anyway medically for the treatments that they are prescribing, but we don't need the extra hassle of some other entity sending a drug in that we have no control over. Now, I love this one. Their name is Sharks, which I think is very apropos. SHARX. They're based out of St. Louis. Now, this is interesting because the CEO had a child that had a rare disease, and they found a resource that paid for all of their financial costs. So he said, well, this is really great. I'm going to found a company so I can do this for everybody. And that's one of the reasons why he thinks it's okay to sign up all these employed insured people for the free drug program, so that because he was able to do that. They work with multiple PBMs. They fill prescriptions through non-traditional channels, is what they promise. They do. They receive a fee per employee per month for what they do. This is an interesting company because they do a lot of YouTube videos, and they make these videos available to for ads, and also for employers to play in the cafeteria to help educate their employees about what this new program is. And they're usually short. They're 30 minutes or 30 seconds or less. So I've given you a link to where you can see some of the videos in case you want to look at them. Now, if you're looking for their website, don't go to sharks.com. It's sharksplan.com. There is something else called Sharks out there that you don't want. But right in the videos, they put a caution that says medications could take 2 to 4 weeks to arrive, or 5 to 7 weeks, depending on whether they are shipped domestically from Canada or overseas. So you can see not only is the process of doing the application and waiting to see if they're approved, and then waiting to see if they're going to get dumped back into the system or not, there's also a delay for the patient even getting the medication that they need beyond what we might think would happen if it was only domestic. And certainly much longer than it would be if we had delivered the drug. So what does Sharks call a high-cost drug? Anything that costs more than $200 for a 30-day supply. If it costs more than $200, they are now saying this is non-essential, and we can get it for you, or we hope we can get it for you. Here's a list of some of those drugs right here. You'll recognize some of them. I won't go through the list. So these are some of the results that Sharks promises its employers. They're telling us that for large employers, they're saving $4 to over $1 million. Now, remember, their savings are calculated on the wholesale price of the drug. So it's not really savings, and it's not really dollars that the employer paid. It's just what they are telling the employer the value of their intervention was. In California, California Business Journal had an article, trying to see the year, I don't remember exactly when it was, but how to get to lower RX cost. Prescription drugs are the fastest growing cost driver in healthcare. Now, it was written by a reporter who writes frequently for the California Business Journal, in combination with Paul Pruitt, who is the CEO of Sharks. So I couldn't find its contracts, because sometimes they're just not available, though they're more hidden. But I can tell you that Sharks is in California, and there's a video. There's a group called Benefits Ally, and there are a number of conferences that are held in California for single self-insured employers. And Sharks and these other companies all are exhibiting in California at those conferences. Another one is called Script Sourcing, and I think this is the last one I have on the list. They're based out of Bonita Springs, but they also have a Baltimore address. This, I have one more beyond that. So rather than use a PBM, they're telling the employers to use script sourcing to source the specialty medications. They're paid on a percent of savings, but they also are right up front. We have an international drug savings program that's paid at 25% of what you saved, what we tell you saved. Now, I was at the Florida conference, and these employers were saying this is the best of the best. There were pharmacies there that were doing this. And I played the dumb blonde routine. I didn't twirl my hair, but I said, I thought that international imports were limited by law to just a personal use for up to 3 months. And the CEO of this pharmacy that does international imports said, oh, yeah, but we do it anyway, and nobody cares. Nobody is stopping us because the bottom line is we're saving money for employers and for patients, and nobody's going to challenge us at the kind of drugs we're coming in. Now, some of you may remember Catherine Eban. She wrote a book called Dangerous Doses in the early 2000s, and that was about some of the back end drug trade that was going on, where people would take legitimate drug, they would adulterate them, they would relabel them, they would rebottle them sometimes in their garages in Florida in the heat, and then get them back into the main system. And these were drugs that were no longer potent. They were less potent than they were supposed to. There was less in it than there was supposed to be. And her book, Dangerous Doses, did a really good description of that. From that, we learned how important it was to have a pedigree of every step the drug takes to get to us. Now, that's still not common. It does happen, but it's not absolute for every single drug. We certainly don't get a pedigree for drugs that come from overseas. Catherine Eban has written 2 other very interesting books. They're both called Bottle of Lies. The first one is Bottle of Lies about the generic drug industry. I have not read that one yet. The second one is Bottle of Lies about the Ranbaxy, which is an Indian drug pharma. And not casting dispersions on everything that is done and comes from India. But some of the points that she was making is a lot of the drugs that are manufactured in India, they don't have the formula. And so they have to reverse engineer them. So to me, it's like, I'm a baker, giving me a piece of spice cake, and I take a bite of it and I say, tastes like there's this much cinnamon, this much cloves. Oh, there may be pineapple in there. And guessing and trying to make it based on what I think I tasted or was able to discern from the sample that I have. Now, it's one thing to reverse engineer a spice cake. It's another thing to reverse engineer a drug that is either an anti-cancer or helping offset as a supportive drug, the effects of cancer drugs. That is not something that we would want. And the other problem is that there may be FDA inspection of manufacturing facilities in India specifically, but for the FDA to go over there to inspect, they can walk into a manufacturing facility in Alabama without notice. They can't do that overseas. They have to get a visa. They basically have to announce months in advance that they're coming. And it's very scary to read Catherine Eban's book on the Ranbaxy, because things that I would normally think are how manufacturing and inspections are handled, the curtain is just pulled way aside. So we also have that's part of the reason I have such a concern about these international drug savings programs. We have lists of other savings here. This is just script sourcing messaging. Of note in here is that they say, please request a 3-month supply of the medication with 3 refills. So we know that cancer patients often may have a health status change. They may not be able to continue on the same drug that was the original prescription. So this is leading to incredible drug waste if you're asking for almost a year's supply, 9-month supply, with the first prescription. But they do say here that new to you medications have to be domestically prescribed, filled, and taken for a period of no less than 30 days. So that is their nod to the fact that patients' prescriptions may change, but they have to make sure they do it within 30 days. Otherwise, they're in the loop of the script sourcing. In California, take a look at the insurers and the brokers that are, in fact, your own employer uses a broker or an insurance to help find what health benefit insurance you're going to use. I would go and ask them, what do you know about any of these companies? Because Newport Beach Benefit Insurance Solutions right up front explains their script sourcing prescription drug program. And I give you the link there. Excerpts from some of the services agreements for script sourcing, the International Pharmacy Program. They're saying we're going to get manufacturer assistance, but we're going to bill you 25% of the savings that are realized by you based on our pricing. So for the one example they give down here for Sovaldi is that they're claiming that the employer would end up paying script sourcing $21,165 for a 90-day supplies of Sovaldi. That's where they're getting, and they're getting that for not really having done anything other than pretending the employee wasn't covered, calling up the manufacturer, getting the free drug, and putting the patient into a state of disruption. This is my last one, Save on SP. They're based out of New York State. We know that they're connected to Cigna and Express Scripts. They are defined, they are very upfront about non-essential health benefits, and they require that any drugs are filled exclusively from their Accredo specialty pharmacy. And if the patient doesn't take the drug from Accredo specialty pharmacy, they can require the patient to be on the hook for the full value of the manufacturer's copay program. So if the copay program value is $20,000, not enrolling in Save on SP could cost the patient the full $20,000, which would not then apply to their out-of-pocket maximums. And they charge 25%. Now, most of these companies were founded in 2015 or later. One of them was in 2013 and has been around for a while. I think it started as a specialty pharmacy. Save on SP in California, the county of San Luis Obispo uses them. Often when a county or a municipal agency uses them, they end up having the exact contract written into their minutes of their publicly available meetings. So that's what the link is that you have here. For this county, they have, these are the drugs that I pulled that were out of the full drug list. And you'll see most of them I tried to pull the cancer drugs. Also, Santa Barbara County is using them for their employees for over 250 drugs. And they say that the conditions that they cover are not limited to, but include hepatitis C, multiple sclerosis, inflammatory bowel disease, rheumatoid arthritis, psoriasis, and cancer. You'll notice that a lot of these are targeting employers that are having often have lower salary employees, which means that they're more likely to qualify for the income limits of the assistance programs. Now, this is a little bit more information about the Johnson & Johnson's lawsuit against Save on SP. It was brought in 2022. It was interesting because Save on SP moved to dismiss and said, they shouldn't be suing us. Court, please make the lawsuit go away. And this is where coalitions started to get involved. And the Aimed Alliance is a volunteer group of lawyers who, when they see something that doesn't make sense, they will put together the legal brief to argue for the court why they should be doing a certain thing. And in this case, they put together a brief that said, court, you shouldn't pay attention to Save on SP's motion to dismiss the lawsuit. The lawsuit should continue. And in California, you are part of a national group called the National Oncology State Network. And that the NOSIN signed on with the amicus curiae brief, also the Connecticut Oncology Association. I'm not sure, Nicole, if you were able to have MOASC sign on at that point, but you can read the brief there, and it's basically discussing all of the reasons why the lawsuit should continue forward and all the challenges that this is giving to the patients. Watch my time, I'm in good time. Okay, so what are the consequences? There's real consequences, there's potential consequences. We've already talked about their general approaches, that they're targeting drugs above a certain cost threshold. They're targeting drugs that they may not be able to get otherwise through their specialty pharmacy. So they say, don't use that one, use the one we can provide, or just the price or disease. Or if they know that they can get a good patient assistance program, and we have seen them say, I'm not going to let you use that drug because those guys are onto us and they won't let us sign up the employee. So let's sign up the employee with this other one. We can still trick them. So, and they're turning away the employer, they're charging the fees, and then the employee gets back in the system. Whenever somebody comes up with an argument, they have a workaround, or they have a message that says, this is why we make sense. Essential drugs, we'll just call them non-essential. If there are income requirements for coverage, what they do is they're adding all of the family member in the household count. So, and they have decided that the income requirements are for everybody in the family, not just the patient. So the more number of people raises the percentage of the federal poverty level qualifications. So it's one way that they're gaming the qualifications for the patient assistance that comes in there. They're pretending to make the patient look uninsured. They also have software, and they are seeking out patient assistance programs in the manufacturer copay. They're searching, and they'll call them up, whether it's a hub or the payer, the manufacturer directly. They'll call them up and pretend to be an advocacy organization, saying, I have a patient that is having trouble getting this drug or that drug. What is your program? What can you provide? And the challenge is that these hubs don't yet know whether the person on the other end of the phone is a patient or is somebody from one of these AFPs. And then there's also the reverse benefit discrimination, which is an issue for ERISA. If you have employees that make above those income requirements, or they're not able to get them the free drug, and they can't get them the international drug where there are no income requirements, then they're out of luck, and they don't get to have advantage of supposedly the benefits that the lesser paid employees do. And that's a problem because there has to be parity under the ERISA plans, health plans. Not all PBMs or health plans are happy with them. Some of them are working with them, and some of them are not. So this, there have been articles talking to employers to say, look, we do our estimates of your premiums based on actuarial numbers. If you're pulling out these high cost drugs, you're screwing up the numbers that we're able to give you for premiums. So it's frustrating to them as well. And I was fascinated to find Blue Cross Blue Shield of Kansas has actually written a blog post for employers about what they should think about the risks of considering a specialty carve out. I include this because as we put together our own talking points, these are some talking points that we can refer to and use. So basically there are ethical questions, there are compliance issues. It's putting the health of your employees at risk, unsafe practices that affects employee morale, cost savings isn't guaranteed, and there's danger with these programs. Another item that comes up is they're not sustainable. Vivio Health has come out with some very interesting descriptions of what some of the compliance issues for them, and they're linked back to some of the tax code. One of the issues is basically if the health benefit plan administrator is paying these companies out of employee health plans, then that's a misuse of the health plan funds. But I give you that to you as a reference. And this is the one that I've already gone over this, that the savings that they're claiming are questionable, that they don't include the rebates. There's just no way to really back into it to prove it. They're telling the employer what they're saving. This is the information. I'm getting to the question that somebody just asked about what can we do. FDA has said in their campaign to patients, this is how you can be safe. And you're safe if your online pharmacy is in the United States, requires a prescription, has a pharmacist on staff, and is licensed with the State Board of Pharmacy. You are probably at an unsafe site if it's not licensed in the US, doesn't require a prescription, doesn't have someone on hand, and sends something different, often deep discounts, too good to be true. So the FDA itself has said, we do not support foreign imports. They are not safe. They are not what's to be expected. And the frustrating thing is that there are towns and there are states that are considering importation on a wholesale basis. I don't think any of them have done that yet. So we've already gone over the risks of the carve-outs and that they're draining from the soup kitchen types and that type of thing. The impact isn't just listed a cancer drug. So we have the ability to work with other specialties when we're challenging these. And the awareness is starting to grow. We've talked about these. We talked about the lawsuits. This is some of the details about the lawsuits. These are the details about what's in that amicus curiae brief. And here's the headline that Payer Matrix put out. Leading patient advocate slams AbbVie moves to deny vital drugs to needy patients. So I have a copy of that for you. And then they did file a brief about Payer Matrix as well, because they also moved to deny the lawsuit. But they then went back after those who signed on the amicus curiae brief to say, well, you shouldn't listen to any of those entities. And there were, I think, 23 of them, because they've taken money in the past from AbbVie. Well, I was one of those, Connecticut Oncology Association, and I answered back very quickly to say, I have set support, and I haven't even spoken to any of the AbbVie people about this. This is a bad program, et cetera. So now we'll do our last 10 minutes before we get into some questions about how do you prepare and how do you plan? The big challenge that we have right now is awareness, because many of the employers either don't know about it or their brokers haven't, they've signed them. They say, we've got this great program, sign up, and they haven't given them the details, or they're not even sure that they're doing it. So we have to try to see where it is. And the best thing to do is to document. Every single one of us should have the employer of every one of our patients in our records. And then we should start to look. If we're starting to see denials, if we see patients walking in the door saying they are not covered for this drug, and all of a sudden 5 have come in from the same employer, or 10, then that's a pretty good indication that that employer has made a benefits change that is using one of these AFPs. So we're going to have to start to track that. We're going to have to start to look at this for employed patients. I was talking to a patient advocacy group, and they said, well, the first thing we do when we get a patient is the patient says, I'm not insured and I'm not covered for this drug. And they say, well, let's see if we can get you some insurance. And the patient then answers, well, I've got insurance. I work for Acme Screwdriver, but I'm not covered for this drug. Now that's the heads up. That's the red light that comes on for the patient advocacy group that, aha, I'm dealing with one of these AFPs. And that way they're not automatically sending them on to get to the free drug program because they don't want to exacerbate the problem. So if we can start to document the diseases where we see this pop up, or the drugs or the employers, it makes it easier for the practice or for MOASC collectively to then go and talk to the employer and say, I don't know if you're aware of the details of these programs, but here's the downside of them. And they're not sustainable, and they're disruptive to patient care. And by the way, for quality patients that qualify, we're already getting them signed up. Document the adverse consequences. When you've identified a patient that's with an AFP, we need to be able to track how long is that patient waiting before they get their drug, if they get their drug. What seesaw are they going through emotionally? What are their problems? Because when we go to talk to the employers, we have to be able to say, this is what's happening to your employees. We can't just say it's a bad thing because we don't like it, because they'll just turn around and say, well, that just means you're not able to dispense a drug and you're crying wolf because of that. Align with others, whether it's NOSIN, MOASC, the Angel Alliance, when we have to develop talking points about the key issues, and we need to be able to communicate with the employer groups. Get involved with the employer groups in your area. Maybe, and we're going to look at this at a national level, but get involved in the California Business Journal. We can get articles in these and present the other side of the story with a nod to Paul Harvey. So the challenge is we have to become an advocate to be able to help those that don't understand these. If we see something, say something. The bottom line is this isn't money. It's not free pus of money just waiting to be taken. It's money that's being used and resources that are being used for people who actually need it. If you're selectively uninsuring employed insured patients, for specific disease based on the cost of treatment, that's reprehensible. But it may be naive. They may not be doing it on purpose. They may not know that they're doing it. And these third parties aren't telling them everything. They aren't telling them that this money is coming from a pot of needy. They're tempted, and yes, they need to know what the implications are. And we need to be very upfront about talking about the importation of drugs for vulnerable patients. This is illegal on a wholesale basis. It's dangerous. It's not monitored, and it's unsafe. But we can't be naive. The employers that we're going to be talking to are scared. Their costs are high. So we have to turn around and be able to say, we understand, we want to work with you. This is what we're doing to try to make sure that your patients are getting the right care. We're actually watching them. And if they have health status changes that require a change, we can dispense and we can change that in a heartbeat. So you're not paying for a 9 months worth of drug that the patient actually cannot use. And you think about what you would do if, as an employer, if these companies pitch these savings to your own benefit. Now they may be, because I spoke to one pharma company and it turned out that one of their employees who was using assistance to receive their own drug all of a sudden was caught up because that employer was using one of these AFPs based on the recommendation of their broker. And the employee all of a sudden could not get their own drug. They didn't know that their broker, and they went to the broker and the broker said, I sign up every one of my clients for this program because the broker gets a commission on the savings. So there's money being taken out of the pot of healthcare all the way up and down the stream with these, the SP, the specialty pharmacy that's filling the prescription gets their piece of the pie. The broker gets their piece of the pie. The AFP gets their piece of the pie. And all of a sudden the costs are getting higher and higher. I don't know what the tipping point is. We have not reached the tipping point. We're worried about this, but I can't tell you that every single access for patients has been drained. We have to be very aware of the facts. So become vocal, start tracking, check what's going on in your own benefit organization, use MOASC, use NOSIN, and use me as an ally and resource. I'm trying to coordinate and collect together as much as I can. Here are some resources. These are the 4 editorials I've written on the issue in oncology practice management. And there was a very interesting Center for Health Law and Policy Innovation out of Harvard Law School that just hit in January that was talking to employers about what should you be asking about essential health benefits. So I included that as well. And those are mine. And I hope I've left enough time for questions. And thank you very much. I appreciate the time. And hopefully we're going to be able to, in another year, say that we are not seeing as many of these AFP programs out there.
Thank you for that information, Dawn. So if anybody has any questions, feel free to type it into the chat or unmute your line.
I'd love to hear if anybody else has seen them.
I have a question.
Yeah.
Oh,
Go ahead.
thanks. So my question is, you mentioned at the beginning that some of the patient from the health plan denied for the authorization, or like, no, I'm so sorry, not denied. Some of the patient from the health plan has approval for the drug, and then with the very highest copay for this patient, and the patient will comes to like copay assistance or grant or the free drug from the manufacturer, right? So you was mentioned like some kind of the source the patient received that will effective on the cost of the patient, and somehow it's turned back to the patient that they can approve for some certain amount, and then it will deduct on the patient's like copay back with the not affiliated program. So I would like to ask you, what is the solution here if one of the patient has like a TPO insurance and they normally has a very high deductible and the cost of for the specialty drug, and they normally do not have the grant during of the year. Effect beside of the free drug from the manufacturer, we cannot control about that. Do we have any solution beside of the contracting directly to pharmacy specialist?
Well, one of the things we haven't addressed on a national level is, and I think this is getting to where your question is, what do you do with the patient who has a high deductible and has been used by one of these programs and denied for assistance and then dumped back into the insurance again, where they're back with a high deductible. And the question that these patient assistance programs are dealing with, because you'll see some patient assistance programs start to say that they will not offer assistance to anybody who's employed. There are others that are still saying, depending on the drug, that they will still offer assistance, but the quick request has to come from the physician and the patient and not through the AFP. So if you have a patient that's been sucked up into one of these programs, they couldn't get the assistance. They get dumped back in and now they're in the high deductible and they can't afford their deduction. You should be able to then apply again to patient assistance for this patient, not as an uncovered patient, which is what the AFP turned them into, but now it's a patient underinsured patient. And then they may be able to get the patient assistance as underinsured, not as what the AFP called them, which was uninsured. Does that make sense?
Yeah, so just want to clarify, it seems like the one is called like an exception prescription, right?
Yes.
Okay, so is it will be provided from the manufacturer or it will be provided from the pharmacy specialist will render the medication for the patient? That I would like to know as well.
Well, the goal here is to get the AFP out of the mixture and completely. So what you want to try to do is, if the patient has been bounced around and then you've learned that they're now covered by one of these, to stand your ground and say, we are not going to accept from that specialty pharmacy, and it may have to go to the employer. And then you tell them why you're not accepting from that specialty pharmacy, and then try to get the patient back to you just as they were normally, as underinsured. Did that answer the question?
Yeah, all right. So I may have to take a look detail on some of the website you provide as well, because some of the website you provide is very useful, but just like my question, just try to explain myself and for my employer that like that will be helpful for the patient, because some of the patient will go back and ask, and we need to very, very careful and explain to the patient is it will cost on the patient high copay. So we do have some of situation happen, and we always try the best to accommodate with all, but as I'm saying, my question is related to the real case that happened that like some of the program denied for the patient and it's come back that the patient have to be on the medication, but we don't have any solution yet. Anyway, thank you so much for your answer.
I would try, if you figure out, as it sounds as though you did, that they were under the within the clause of one of these AFPs, I would hope that you might be able to stop before you do anything further and reach out to the employer and say, the program that this employee is on under your health benefit is not a program that's going to help them, and see if you can maybe get an exception for them there, so that you can then just treat them as you would if they were not in the clause of that program, and find whatever help you would for them regularly. And you've also now put the employer on notice that somebody has complained about this health benefit program, and given them a heads up that this isn't as nice as it sounds. And then if another practice does the same thing and another one does, then all of a sudden that employee benefits manager is going to start to wonder what's going on. And then they may drop them. Because a lot of times these guys, when they go to an employer, they're signing up for 3 or 5 year contracts. So one of the goals of reaching out to the employer when you find an employee under their circumstance is to help undermine their confidence in the Save on SP or the payer matrix or whatever it is.
Thank you so much.
Hopefully, yes. Somebody has their hand raised. I can't see.
It was who just spoke. So are there any, oh, can you see the chat?
I see one that says, how do you safeguard the consumer, the patient?
You already answered that. Thank you, Dawn.
Yeah.
That was
Okay.
valuable. So thank you. Very much informative. And obviously awareness is the key to avoid the pitfalls. It's kind of scary out there.
Yes. If you see something, say something. And this is a place where your state society can be very useful because if you can have a number of different specialties going to the same employer with the same messaging, then you don't have to reveal individual patient information, but you can just say collectively we've seen whatever, and it may not be a huge number because remember the numbers are small for any given employer, but just to be able to do a general pushback from the healthcare community to help employers understand that these are problems and they're non-sustainable.
Thank you for presenting that information, Dawn. We appreciate it. We're going to move on to our next speaker. We have a couple of our corporate sponsors that we'll be introducing. We'll come back to Nick Cool from Insight.
Hi, Nicole. Thank you so much for your flexibility, and hopefully I've worked through all of my technical difficulties. I see Dawn is still sharing her content. I may try and share mine here as well.
We weren't going to share.
I'm going to stop share anyway, so that you can have control, Nicole.
Okay.
Because it was only 5 minutes each, we weren't going to share slides.
Fair enough. I'll tell you what I'll do, Nicole. Thank you so much. I will send a hyperlink to a couple of pieces of information that hopefully your audience will find useful. My name is Nick. I work for Insight Corporation. I am a corporate account and GPO director for the West Coast. A big part of my role is ensuring that practices like yours have access to purchase and dispense our medicines or infuse our medicines. We have several on the market today. Our flagship product is Jakafi, which is approved for myelofibrosis, polycythemia vera, acute and chronic GVHD. We have an FGFR2 inhibitor called pemigatinib for relapsed refractory cholangiocarcinoma. We also have Monjuvi tafasitamab, which is in combination with Revlimid for relapsed refractory diffuse large B-cell lymphoma. And we have a new PD-1 inhibitor recently approved in Merkel cell. It's one of the rare conditions that the PD-1s are also approved for. So look forward to talking to each of you about access to purchase and dispense these medicines. They are available through your specialty GPO, and the contracts are available there. I'd be happy to talk to you about any of those items. In addition to my role for access and contracting states, I also participate in a number of quality initiatives. As one of my colleagues mentioned earlier, I'm here at ACCC. We're a sponsor of a very large quality initiative through ACCC focused on enhancing care for patients with myelofibrosis and polycythemia vera. That is one of the materials that I will send you. It is an example of a practice manager and why she ran a quality initiative in her practice and how it benefited her care team, and her patients. And I'll be happy to send that as a follow-up. I would love to have conversations with you about that, any of the contracts, and anything else that we might be able to help you with. And I think with Nicole, with that, that's a really long 5-minute introduction, and I should probably stop there, and I'll stay online as well.
Wonderful. Thank you. We've put your contact information in the chat, and we'll also include it in the follow-up email. All right, we'll move on to Sheree Kotsky from AstraZeneca.
Hi, everybody. My name is Sheree Kotsky. I am with AstraZeneca, and I am the Southern California Field Reimbursement Manager. At AstraZeneca, our ambition is to provide cures for cancer in every form. Our focus has been to treat some of the most hard to treat cancers, including pancreatic, blood cancers, and cancers within the breast, lung, ovarian, and prostate. Currently, we have 6 products with 24 indications. These include Imfinzi, Imjudo, Tagrisso, Lynparza, Calquence, and Faslodex. We also co-promote Enhertu with Daiichi Sankyo. Our focus is expanding indications for these products and exploring novel treatment combinations as well. Patients are always at the forefront of mind in everything we do, from the treatment options to overcoming access barriers with our Access 360 program and providing patient assistance through AZ and Me. Feel free to reach out to me or your local FRM to learn more about our access and affordability resources. But we are just honored to be a sponsor of MOASC and really value our partnership. So I appreciate the time that you have given me today.
Thank you, Sherry.
Sure.
Moving on, I'll introduce Buck Borquist from Genentech.
Hi, everyone. Thanks for having me. My name is Buck Borquist. I am a field reimbursement manager for Genentech in Southern California. I cover all of Genentech's products, including all of the oncology portfolio. And as a field reimbursement manager, I'm not tied to sales in any way. It's not part of my performance or anything. I also am HIPAA trained, so I have access to patient information. So my whole role is to really put patients first and try to see how we can get products covered. I work hand in hand with Genentech's Access Solutions team. And as part of that Access Solutions, there's lots of benefits for people like you and accounts like yours. There's benefit investigations that are done and benefit re-verification support, prior authorization resources, information about authorized SPs, specialty pharmacies and distributors. We have sample billing and coding information that we can give out, resources for denials and appeals, and references for financial assistance options. And then Genentech has its own, the Genentech Patient Foundation. I work hand in hand with them for eligible patients to get free product. And all that information is available on our website. I also provided a handout that can go out later. And then my information is obviously in the chat. So we're always, there's a whole team of FRMs throughout the state, and we're ready to help wherever we can. And I'd be happy to hear from any of you. So thanks for having me.
Thank you very much. All right, we're moving on to Saucy Fincher with Puma.
Thank you all. Thank you for taking the time to give us this little introductory opportunity. I'm Saucy Fincher. I work with Puma Biotechnology, and I'm the clinical nurse educator and work very closely with our regional business director and our strategic accounts manager. So for reimbursement and contracting, I definitely will be your contact person to reach out to the right resources to get it all settled. With Puma, it's a small biotech company. We do have Nerlynx, which is the indication in HER2-positive breast cancer, and in both adjuvant and the metastatic setting. And it really shows, especially in the adjuvant setting, that it's the only TKI indicated in that arena to decrease the risk of recurrence and CNS mets. Having said that, the reimbursement and patient access programs that we currently have are something that are invaluable to you and to your patients. And as we heard earlier with our two speakers, Dawn and Deborah, highlighting to work with your developers, the drug developers and the manufacturers, to really make sure that the patient has adequate access to the opportunities that they need. And with that having said, we do have patient access reimbursement center that I've given the resources to Christy, and hopefully after the meeting, she will post my contact information along with the resources available. Thank you much, and hope you have a wonderful afternoon.
Thank you so much. And thank you all. We appreciate your company's continued support of MOASC and its efforts. So that concludes our webinar for today. If you have any follow-up questions, feel free to reach out to us and we will connect you with the right person or find the answer ourselves. Quick reminder that our next webinar in the series on oncology billing is scheduled for Thursday, October 26th. And that will cover billing updates, payer contracts, and an update on drug shortages. So again, this concludes the webinar. Hope you found it valuable. Have a great day.